Good evening, everyone. This is Elena Rios. I'm President and CEO of the National Hispanic Medical Association. I'm in Washington, D.C., but this is our California, Northern California and Southern California Chapters Policy Forum. This happens to be the last of all the meetings we've done with 17 chapters across the country. We're very excited that we finally came to the end, but we saved the best for last. And this is, in addition to being the California Forum, it is also being supported by Amgen to discuss the importance of heart disease. And I just want to encourage everybody right now with our COVID-19 pandemic, among all our families, especially our essential workers and our poor communities, Latino, African American, Asian, Native American. I want to encourage everybody to continue to enroll or to inform others to enroll in 2 clinical trials. The first one, and I have the URLs here, the first one is the coronaviruspreventionnetwork.org that is being run by Moderna with the help of NIH, and you can get all the information of where the locations are across the country. The second one is covidvaccinestudy1.com, and that is the Pfizer clinical trial. And we are working with NIH and HHS and with Pfizer to help inform our communities so that we have more diverse knowledge about the impact of vaccines, especially COVID-19. And I just, as an update, Pfizer has announced that they have nearly 40,000 people enrolled and are putting forth their approval request from the FDA. The Moderna trial is still ongoing, and we hope that other companies will also continue to enroll so that we can have a safe and effective vaccine for our communities. And then 2 announcements. We have a scholarship that we provide. We have announced all of our scholarship winners. There's about 40 students in medical school, nursing, dental, public health, physician assistants, and pharmacy and medical school, all getting scholarships at a virtual ceremony November 19th. It's free. We ask you to join us. We'd like to ask you also for donations. And our second announcement there is we have an annual conference, which again will be virtual, and we're looking for speakers and exhibitors and sponsors. So I'm not sure. Ben, is there a second slide announcement or no? So let me just introduce our 2 moderators for the evening, Dr. Elon Shapiro and Dr. Margarita Loesa. And Elon will take the first hour and moderate, and Margarita will do the second hour. So let me turn it over to Elon. Thank you.
Well, thank you, Dr. Rios. It's always a pleasure to be with us, and especially right now, in times of change, we have heard so many other new things about COVID, and especially with the Hispanic population in our communities. Here in California, it hasn't been different than other places. We have seen how big the toll of cardiovascular disease involving COVID is starting to emerge. At the beginning, we didn't understand that much. We're starting seeing a lot of, things that we just don't understand, myocarditis, arrhythmias, and other stuff that we have not seen before. They're actually kind of related on time with COVID. And in other words, our community, and as we've seen, and especially tying that with the election time that we are at right now, has been disproportionately actually affected for the past decades. That's why the virus is actually hitting us very low now. But with all that stuff that's happening, what can we actually do? There's 2 amazing panelists today that we're going to be joining us with Dr. Rios to talk a little bit more about what's happening on the community. And I want to introduce Ms. Kimberly Chen. She's the principal consultant from the Senate Education Committee, and she creates health and prevention policies, and she will be talking a little bit more on what's the perspective on prevention pre and post-COVID for our communities. Ms. Chen has been actually very, very involved with multiple underserved community efforts to try to bring equity in absolutely everything. And one of the things that she has actually been very able to do has created that link between education and change in our community. Ms. Kimberly, welcome to the panel. It's all yours.
Okay, well, thank you so much for that introduction, Dr. Shapiro and Dr. Rios and everyone for having me here. Like I was said, my name is Kimberly Chen, and I'm one of the consultants in the Senate Health Committee. And my main areas of work are around Medicaid. So I really look really deeply at our Medi-Cal policy and serve our chair, Dr. Richard Plan, who unfortunately couldn't be here with us today. But I'm happy to pinch hit and see if I can catch you guys up as to what's been going on at the state level. So I think prior to COVID, I think there was a lot of energy and excitement with the this new governor. I guess it's been a couple of years now, but there was a lot of excitement around healthcare and the ways in which we were looking to transform the healthcare system. I think we were really looking forward to really looking at prevention, looking at ways to do systems transformation, particularly for individuals in Medi-Cal, really looking at disparities reduction work, looking at really closing those gaps. And I think for many folks, it still remains a really pertinent issue. As Dr. Shapiro mentioned, I think the COVID pandemic has just really highlighted and really accentuated how stark those disparities are. And so I think many of those efforts will be there in the background, but I think obviously COVID and the response to the pandemic has really taken up a lot of space. My chief work is really around policies in Medi-Cal. I look at legislation that's coming through, analyze it, and provide recommendations to the chair. And so I get to see a lot of the bills coming through. And I think last year there were a lot of excitement around systems transformation in Medi-Cal, the CalAIM program, really looking at underserved populations, really looking at care coordination and care management in a different way. Fortunately, those issues were sidelined. And last year, as COVID hit, we really had to focus in on things that could be done with a limited timeline. And we really focused in on a couple of key issues. And our committee actually heard, for the first time, I think our committee limited the number of hearings we had. And so it really limited the number of bills that we're able to get through. And unfortunately, as it is with emergency type situations, we really didn't have a whole lot of opportunity to work on prevention and disease prevention related issues. I think one of the main couple of bills I could think of was one on addressing blood lead screening and kind of really early prevention. And that's really the one bill that really comes to mind, at least in my issue area. A lot of the discussions have really been around what is going to happen next year. I think folks really ought to keep their eye out for what the budget is going to look like. It's going to be another year of scarce resources. We we're hoping to get some relief from the federal level. Our state budget was built on some expectation of federal relief. Obviously, that's up in the air right now. We're still hoping something will come through, but if those conversations continue to fall through, I think that's going to have a tremendous impact on the ability for the state to keep the programs that we have in place and to continue to deliver services in the same way. And I think there's going to be some hard conversations around maintaining the level of services and eligibility for folks, particularly relying on state programs. But I think for my boss, at least, the issue of disease prevention and still remains top of mind. I think he continues to really care about the ways we can scale up some of those efforts that have already been going. I think there's continued interest from my boss on what CalAIM will look like next year. I think he had a lot of interest in the programs that were being proposed, and we're really looking forward to in the January budget as that becomes released, what kind of things that we can continue to move forward on that front. and finally, you know, in my wheelhouse of Medi-Cal, the state is now, Department of Healthcare Services is embarking on a re-procurement process where they'll be recontracting with all the managed care plans that provide care to Medi-Cal. And so it's a really wonky area, right? You don't really think about contracting as a way to get to prevention, but the contracts are what are the things that are the blueprints to what type of care is provided, what type of expectation we have for health plans, the type of system that we want out there. And so there's a lot of good wonky details that go into that. And I think there's some hope that those contracts, this new process, will really be the catalyst for really prioritizing things like disease prevention and reducing disparities and tackling our equity issues. And even now with COVID, really looking at emergency response issues. So yeah, those are the main things. I think the last couple things I want to touch on is the issue of telehealth. I think, I think it's been talked about to death, I think, in many places, but, what has really struck, at least my boss, as he's talked about, is that I think this very unusual moment in time we're in has really provided a catalyst for a lot of change. And sometimes that change has been really helpful. We've really sped forward on telehealth and moving forward in that front. But I think there's going to be some real questions as to how equitably those resources are distributed in the community. Do people have access to reliable internet? All these conversations we've continued to have. Like, I think it just gets even more stark. And but I think it's really promising to see that happen. I was talking to some community clinics who talked about the ways in which telehealth has really made people much more likely to attend their mental health meetings, right? People do sort of preventive things that they can just talk to their doctor online and really make it happen really quickly. But I think, again, we got to really go back to which communities have access to those type of resources. Are they equitable? And I think for many communities, is it language and culturally appropriate in the way that those things are distributed? I think the last note I'll leave on, I was just on a panel previously before I got here talking about the initial onset of COVID and the cancellation of all the preventive services that folks didn't get to. I think for my boss in particular, it was concerning was vaccination for kids. And a lot of preventive screenings. And I think we're going to be doing a lot of catch up around that. I think there's going to be a lot of, things we find out in retrospect as to the impact of that. And I think those will be things that we will be dealing with in terms of policy and on the front lines for years to come. So I'll stop there and throw it back to Dr. Shapiro and open it up for conversation.
Thank you so much. If it's okay with you, I'm going to leave a couple of time at the end. That way we have some questions regarding the panel. And I'm extremely interested to hear that part, because I agree with you completely that telehealth for our communities was going to be a dream in like 4 or 5 years from last December, and right now it's a reality. Now we need actually to structure, it's kind of, we landed an airplane and now we need to build an airport. That's kind of the philosophy that we are now at. And thank you so much for your insights. I want to invite right now Maria Carrasco. Dr. Carrasco has been part of Kaiser Permanente, and she has been actually very, very, very active to involve equity in vaccinations. We were talking about that part. Transgender care, colon cancer screenings, and other innovative programs for our community that are tough to cook and tough to implement, but she has been doing that part, and she has doing a great thing. And most importantly, she has been relating herself with teaching our future generations of physicians, nurses, and healthcare providers. And Dr. Carrasco, welcome.
Got myself off mute. Thank you so much, Dr. Shapiro. I am quite happy to be able to join the panel today and have a conversation about cardiovascular disease. So I think all of us should know by now that cardiovascular disease is the leading cause of mortality for our nation as a whole. And it's quite clear it's number one. And so with that is, how do we try to do prevention in an effort to really reduce the cardiovascular risk that exists, especially in our communities, is really the conversation today. And the hypertension and hyperlipidemia are major causes of coronary artery disease. And with that follows also diabetes and obesity. And with those in mind, I want to just say that if you have hypertension and diabetes, that doubles your risk of having cardiovascular disease in the future. So my efforts here are mainly to really focus us on prevention and also have a little conversation about the aftermath of cardiovascular disease or having a heart attack, which is the major situation that happens to individuals. So most patients are really aware that they could have a heart attack, but when they're young and they're going through life, they really don't take a lot of stock in taking care of prevention, especially in our community when there's so many other competing priorities for the families to take care of and put food on the table. So with that I will say that prevention is lacking in our communities. I'm happy to hear that there's going to be efforts around that, continuing efforts and challenges, of course, now with COVID. But I know that after someone has a heart attack, patients do listen up a little bit more. They do really try to work towards the prevention of their care and how to minimize having another heart attack, which can be more detrimental, obviously, and causing death. So between the two, I think that my patients that have heart attacks, they are more likely to do better with prevention than those that have not, but those that have not are the ones we really need to focus on. So for example, diabetes definitely, as mentioned earlier, is one of those areas that predisposes you to being at risk for cardiovascular disease. And 68% of our diabetics die of heart disease or have a heart attack in the future, where over the age of 65, where 16% of the group 65 years and older will die from it. So with that in mind, I wanted to go ahead and next slide, move us to this one. I want to definitely touch on high cholesterol, really hyperlipidemia, as the doctors would call it. Is 38% of our population nationwide has high cholesterol over the number of 200, equal to or greater than 200, which really predisposes individuals to having coronary vascular disease. And you can see on the picture on the left, we have a nice artery. At the very left is a nice squeaky clean artery, usually something we see when you're young, birth to maybe teenager, even early, maybe 20s. But as we get older and dependent on our continuous health behaviors around our dietary choices, those arteries get filled up with fatty tissue that builds up in the arteries, as you can see, and which causes narrowing of the artery, as many of us know, which puts us at risk for having a heart attack. That really is the determining factor here when it comes to cholesterol and what it can do to you in aiding to having a heart attack. So really things to consider, that other health conditions that put you at risk for having high cholesterol is having diabetes and being obese. They both work against you, those two things. So it's important to look at prevention in those areas. And then there's the familiar hypercholesteremia, which is something that you can't prevent that. That comes with the family. You could assist with it and try to do your diet, but you have to be on medication. But the other two really are something from a high cholesterol level that can really be worked on. High cholesterol can be worked on through loss of weight, exercising, watching your fatty intake. So there is something you could do. And as a doctor, I will have to tell you that if my patients come in, get their lab test, and actually take their medication, they will do good with their cholesterol. We will get their cholesterol down. It's only when they don't take their medicine or cannot come in for whatever reason that we are challenged as a community. So next slide. Okay, so I'm going to just briefly mention and go through a couple of slides briefly, because diabetes, as a primary care physician, I will tell you diabetes has been really that thorn in my side and most difficult, challenging part of my care to my patients. And unlike hypertension, unlike high cholesterol, diabetes and obesity have been very, very challenging. And it's because it has a lot to do more with the patient also doing their part in really monitoring themselves. So diabetes, in general, the prevalence of diabetes in the nation is about almost 11% of the population. And this is from the report done by the CDC this past year. So with that, we know that. But unfortunately, at the very end of my slide, you see that we have almost 3 times more patients out there in the nation that have pre-diabetes. It's coming. it's really coming, and it's really a scary thought as a primary care physician, how all these pre-diabetics will now become full-blown diabetics in the near future if we don't do anything. So prevention is key. Next slide. And so this just is to emphasize that diabetes in Latinos, there's more likely to have diabetes as a Latino than as a non-Latino white adult. Also more likely to end up in hospitalizations due to end-stage renal disease, and then also to die from diabetes as a result in comparison to our non-Hispanic white population. Next slide. Okay, so this, Ben, I'm gonna go quickly on these, so let me just briefly kind of tell you ahead of time. Here it really, that breakdown of almost 11%, you could see how our non-Hispanic white population has a lower percentage of diabetes across the nation compared to the Hispanic population. And we know that the Hispanic population is a very diverse population. And that, right below that line, you could see that of those individuals with Mexican descent have a higher percentage of having diabetes within the group that we're talking about. And I think that's very important because as a whole, the Hispanic population is about 65% of Mexican descent. And so that does impact it. Luckily, diabetes is not a huge issue like right now, 11%, but it's been growing over the years. Next slide. Here, this is just a quick slide to show you that our Latino males have a higher percentage of diabetes than our females. And then you can see the other populations. Next slide. And here is, this slide is important to me because of the fact that education of the individual really puts you at risk for having more prevalence of diabetes. And out of the group that you saw earlier, this is for all populations. Individuals with less than a high school degree had a higher percentage prevalence for diabetes. Remember, the average was 10.5. So you could see that. And on the far right, you can see between men and female, there really wasn't that much of a gap. It's a tiny gap. But as the education improved, you could see that the prevalence of diabetes decreases as a whole. But then if you look to the right, the disparity between male and female increases where females do better with the higher education. So just something for us to know of the reality that in general, men tend to really still be a little bit more challenging in managing with respect to diabetes. Next slide. So just from the previous slide, I wanted just to mention that obviously the socioeconomics has to play into that. And in our communities where our patients come from really are the ones that we're speaking to with the lower educational level. That's why health literacy is so important as a prevention path. This just reminds us that Latinos will die as a result of diabetes, will die more than our non-Hispanic white. Next slide. On this one, I think many of us have seen this type of slide in various variations, but it really speaks to the fact that there are determinants of health that are in the control of the medical care team, and there's others that are out of our control, which makes certain medical conditions more difficult to manage. Hypertension, usually we know a couple things about hypertension and high cholesterol. If we're able to get the patient to take medication, we seem to have better success for the most part, unless they significantly gain weight. But if you're talking about obesity and diabetes, those two are more challenging. So I think as a medical care team, we need to recognize that there needs to be more of a push to really looking at how can we help our patients with having healthy lifestyles and healthy eating behaviors. Next slide. And this is just like a quick recap, and I'm sure if we have a lot of physicians in the group, this is very clear to them, but I always like to make sure that I'm clear in my mind with my patients is there's the issues that the patient has that I have to recognize. There's medications that I will give that I have to make sure I'm very clear about why I'm doing it. And then there's the piece about how can I do a better job as a clinician to get the trust level with my patients much higher so that they will be able to follow my directions in a better way and connecting with them. And one area I have found is that the lack of giving patients positive feedback is always the last thing we do. just in general, we always point out negative things in people and we don't give people a positive feedback. This same thing goes with diabetes or any kind of medical care that we're giving with any chronic disease, is we need to give them some positive feedback and say, well, you know, positive. Yes, you gained 3 pounds, but this is good. At least you didn't gain more. I think we're going in the right direction. You're doing the right thing. So I think for me, that's a lesson learned over time that has been very important to really get my patients to get that smile on their face instead of that frown of telling them the bad news and getting them not to want to come in. And so my focus has been on what can I do for the patient. That's that far left column there, is how could I address those issues for them. Next slide. And this one is pretty much a recap. There's been some work in this area, and for some of us, we might feel that doing what's on this slide may be difficult and take more time, but I will guarantee you that if you invest in the beginning, your future encounters with that patient will be better because they will trust you even more. And clearly medication is a huge thing, and some data done by the Robert Woods Foundation, research I should say, was done that actually showed when a doctor writes a prescription, regardless of what it is, 50% of the time people will be taking that medicine. So what happened to that other 50%? That happened to be a result of not knowing why they're taking it, not trusting that they're taking this medication. There's a lot of things that are forgetting, whatever it is. So we need to recognize as doctors, we really, clinicians, I should say, we should be making sure that we do break down that information around medication. It is so, so important for that. And that is part of also the preventative healthcare is in the community, is ensuring our patients know that they need to really, if they're given a medication, they need to ask certain things if the doctor doesn't voluntarily provide it. We have to empower our patients with that information from the prevention piece of it. Next slide. And this just speaks to health literacy. Bottom line is patients will not tell you that they are having any issues with respect to understanding what they're saying or asking you to repeat it, and they will use various coping mechanisms to pretend that they get it, and then you walk out the door thinking everything's fine and it's not fine. So you really do need to have clarifying conversations with the patient to ensure that they know that you want them to understand what's going on. Next slide. And this is just a very an obvious slide for us, for those of us that practice primary care with our adult patients. We are that far left little box, the medicine piece, and then all the other hard work is our patients. But I would have to say is I spend a lot of time really talking up the issues, the importance about diet, the foods, the exercise, the education that they need to get, because I find that an educated patient that has knowledge of their disease will be a better patient and have better outcomes and a healthier future. So I like to just emphasize the fact that my job is not just the left, but it is the rest in talking to my patients about, and any medical condition, not just diabetes. Next. And because we are talking about cardiovascular disease and the importance of it, meaning that we do not want to have patients die of cardiovascular disease or a heart attack, is really kind of looking at this slide as what can be done for prevention. Although this slide talks about diabetes, it really is about pretty much any medical condition that we have. So on the far left, that really speaks to diabetes. On the far right, I will have to tell you that high blood pressure, diabetes, and high cholesterol all have to be managed with diet, exercise, weight loss, and medication. And medication is not enough alone. It's just not enough alone, I can tell you that. Then of course, stop smoking is important, and then working on obesity or being overweight is key. And all of us know that 2/3 of our nation is overweight or obese at this point in time. So next slide, as I'm trying to wrap this up, next slide. This is just the main thing for me, and I'm just going to do the takeaway here, is really getting to the value proposition of our patient, regardless of what medical condition we're trying to assist with, is really looking at the prevention of why they need to work on prevention and to help them and with their medical condition in order to minimize the cardiovascular risk that exists. my one thing that I do as on a clinical basis on every patient that walks in the door that I'm managing for a chronic disease is I talk to them about their weight, their blood pressure, and in this case, if I'm talking about diabetes, I will talk about their diabetes level, their cholesterol level, whatever it is that they're also there for, because those all go hand in hand. And if there's one thing that my patients will always say is, they will always walk away and say, yes, I know I need to stop eating the cheese. And all of us, although we love cheese, I will tell you that I love cheese. I do not eat it regularly. I don't even buy it. It's not in my home, in my refrigerator, I should say, because of the fact that cheese is the main culprit for having you gain weight, because there's a lot of calories. It's very fatty. It's contributing to cardiovascular disease, as spoken about earlier, very much for that. It's also having high salt diet, a high salt level, and then it worsens your diabetes. So that doesn't help with this. And then the cheeses that I'm talking about is really the cheeses that are processed cheeses for sure. For sure, processed cheese is really what I'm talking about. And regarding the different types of cheese, look in the back of the cheese and see how much chemicals are written on them. Then you will know what we're talking about, okay? Those are the processes where they have a lot of additional stuff in them. So anyhow, with this, for me, it's really one thing, walk away, really get away from the cheese. It will help your blood pressure. It will help your high cholesterol. It will help your weight, and it will help your diabetes. Those are 4 things they could walk away with, just that one thing, reduce it. I cannot tell them to stop it because no one likes to be told not to do something. I just say, let's avoid it. Let's eat it less, okay? So that would be important. Go ahead on the next slide so I could wrap this up for us. This is just from the physician level, and all I'm going to say here is we need to communicate with the patient in the way that they understand. We need to commit to the patient, saying that we're here for them. We are their coach. I am not their advisor. I am their coach. I am there hand in hand with them, and I need to repeat the information so they get it. Next slide. And I'm just going to transition over to next slide. That's just a quick thing. Next slide, let's finish this up. I have my last 2 slides are on COVID and cardiovascular disease. I will tell you that the chronic disease issue now with COVID has been really detrimental. Our patients have not been showing up to clinic. They are afraid. And these telephone appointments have been really, really, really helpful, but we still need to get them in. We still need to figure out what their blood pressure is, what their diabetes levels are. So this has really impacted our community, and worse for those patients that have already had their sugar out of control, that have gained at least 3 to 5 pounds due to the pandemic and not moving as much. It's really been an unfortunate situation overall for our communities at this point. And then my final slide, if you could go to the next one. Next slide, I'll go to the next slide. Go ahead and go to the next slide. I wanted to say that people say that having the comorbidities of diabetes or hypertension or any of the other diseases that are listed by the CDC, that they do not cause you to get the disease, meaning the COVID, they cause you to have a poorer outcome on the disease, because any of those chronic diseases cause you to really have your immune system is not what it should be, especially for diabetes. And I just wanted to share that in California, since we're talking about California, we have our state is 39% Latinos, but almost 50% of the deaths, of all the deaths in California, have been Latino. And this is really tragic when you look at it from that perspective from that. And later on, as more research is done, we're going to find that there's going to be a lot of obesity and a lot of diabetics that were in this group of people who died, unfortunately, from COVID. And then the next slide is just some walk-away actions that we have to do. And it's just mainly about what can we do to decrease people's possibility of developing coronary vascular disease. By prevention efforts are really important. We do not want our patients to have a heart attack, because that's an after fact. They will be more complicit. They will comply more with all the prevention. It's the ones before, which is a larger group that I'm talking about. And then, trying to minimize the complications and increasing our patients' lifespan is really what it's about. And then in closing, I wanted just to say that, you could go to the next slide. In closing, I have to say that as a clinician, I take a lot of responsibility in saying that I am there for my patient. I want to help my patients do better and climb this hill that they have to climb with their medical conditions. I need to reach down. I need to be the one pulling them up that hill when they're tired exhausted, depressed because of whatever the medical condition is, I have to be the one that actually coaches them up that hill so that they could reach the top and really have a better life for themselves and their family. So I think in closing, I'll leave it at that. And if there's any questions, I'll be happy to answer them. And sorry if I went over.
Okay.
Dr. Carrasco, thank you so much for that. I'm very saddened to hear about the cheese, but I will continue following for sure the guidance on that part. And you know, there's tons of healthy foods, and I'm going to share a quick thing. Everybody's asking for the secret diet to lose weight and do the thing. And I actually going to share with the forum right now in 2 seconds the Shapiro diet. The Shapiro diet is a trademark right now that I started right now in COVID. It's stop refreshments, stop papitas, stop anything that has high calories that you do not need, stop it. And that's the Shapiro diet. And right now I'm going to transition right now with Dr. Rios. Dr. Rios has been an advocate for a lot of the disparities, to actually fight against disparities in our communities. She has been creating part of the NHMA, but most importantly, an advocate on how to bring information to our community, how to unite physicians, providers, dentists, anybody that is actually on healthcare, and make sure that we are being heard and we have a forum to interchange ideas. Then Dr. Rios, welcome.
Okay, Ben, you can go to the next slide. So just a little overview. I'm going to present some federal and important policy aspects that NHMA is involved with and recommendations. And then I'm going to have Martha Zaragoza Diaz will partner with me on discussing some California leverage points for policy. This is really to make sure that our audience is engaged with advocacy, and NHMA is very interested in being more involved at the policy level in Sacramento. Latino population overview, everybody knows we're 60 million, 18% of the population, 63% are Mexican American. But what people don't realize is we're a very young population, which means we have the working economy. You know, we are the working economy of this country. Young families buying their first homes, you know, but are still low income and living in crowded households because of multi-generations and mixed families. Many of our families still have undocumented grandparents or young undocumented farm workers, for example, with limited education and English proficiency, but large families, which is our really #1 asset. In terms of healthcare, we are the greatest group that's uninsured. As Maria just explained eloquently, we have limited doctor visits and health literacy is a major issue. And we are also underrepresented in medicine, public health, and clinical trials. And this is very important for California because California is such a minority state. The Asian, the Native American, the African American, but especially the Latinos need to be represented in healthcare, and especially as leaders. And our occupations, you know, we have all these occupations where we just can't stay home. Next slide. The other big overview is COVID-19 and Latinos and the national trends. And get this, with only 30% of the country having racial and ethnic data, we are 3 times the non-Hispanic cases, 5 times the non-Hispanic hospitalizations, and 2 times the non-Hispanic deaths. It's horrible, and we definitely need data collected on race and ethnicity in this country everywhere in healthcare. In terms of heart disease, the #1 patients who died from COVID from New York to Texas to California have been those with heart disease. It's no wonder because heart disease is the #1 killer in the country, and we have to do something about high cholesterol, high blood pressure, and all the people living that have already had a heart attack or have stents in their, you know, because of angina. It's just so important. And we also know that Latinos cluster in the poorest zip codes, and I want to commend Kimberly and Assemblyman Arambula and everyone else that is involved in developing healthcare policies. There is a very good California Health Equity Index by Census Tract that includes, it looks at poverty and food insecurity, stress, car ownership, the technical divide, and other things. Next slide. The strategies for improved Latino heart health include, of course, a major education campaign. And I do think we have to, even with the limited budgets that Kimberly is talking about, if we're going to do something about COVID, we need to do something about obesity, and education campaign on heart disease, and really take a look at redirecting resources to community-based organizations, not just the big hospitals and the big healthcare systems in California, but it's our community-based organizations, and it's our churches and it's our clinics that are going to really get to our communities and educate them. They're the trusted partners. And we also need a new program for our parks. That's where we have physical activity. We don't go to gyms. I mean, who can afford going to a gym? But we have environmental issues too with climate change that needs to be addressed, and economic support needed for jobs. And I think we need to have more job training in the healthcare industry, because you can't outsource healthcare. And also for food and housing, that's going to be so much more important as we lose our, our jobs. We're going to have higher unemployments over the next year. And of course, as Maria already said, we need to have the regular physician and medications, labs, et cetera. Next slide. Healthcare Policy 2020 has been all about coverage. We really need an increased insurance coverage for the undocumented, whether they're in California or they're along the border or they're all over the country in detention centers. We have a major need for coverage. We need Medicaid expansion in every state. We need Medicare age to be dropped. We need more doctors and clinics, mental health, rural health. We need the disproportionate share dollars to our hospitals. And of course, we need Latino physicians. And to make it more affordable, the Congress has looked at tax credit subsidies and looked at pricing of drugs and other things. And the other issue for us, again, is the public charge, which was actually enforced in February and then not enforced because of COVID, thank God, and DACA and immigration reform. And we need health equity, not only in medical education, but in research, in our clinical trials. Next slide. So some of the legislation was really about supporting healthcare, all of the PPE for hospitals and doctors, all of the telemedicine, all the testing supplies, all came from Congress. A lot of support for the economy, for our employers, taxpayers, airlines, other industries, and health access, including workforce sent out from the military with ships, with hotels targeted to areas of surges. And then we have the whole issue of our vaccines and clinical trials with Project Warp Speed. NHMA is a part of Project Warp Speed consultancy for HHS. And also we've been involved with the National Academies of Science, Engineering, and Medicine reports on the distribution of the vaccine. Next slide. I think some recommendations, and again, this is really about California now. We really do need more economic relief. We need guidance in Spanish. We need more media. We need to support our providers and cultural and language services that our policies can really address. Affordability, healthcare systems, and in the communities. And again, it's the nonprofit minority organizations that need to be supported in legislation, not just putting legislation for the academic health center, for example. Next slide. And then this is just a picture of some of us and going to Congress. This is what we do. So what I'd like to, this is from our 2019 annual conference. And what I'd like to do now is turn it over to Martha to talk about a few specific ways that NHMA and others who are interested in helping us with advocacy in Sacramento, what we can do to work with Kimberly and Assemblyman Arambula and others. Thank you. Martha? You're muted.
Yes. Good afternoon, everyone. I'm not going to go over every slide due to time constraint, so I'm going to summarize the slides. So California has a 2-year legislative session. The 2021-2022 legislative session begins January 2021. Introduction of proposed legislation in all policy areas, including health, begins, but the deadline for the introduction of new legislation is mid-February. Depending on the state's economic situation, new legislation may be limited to bills dealing only with COVID-19 and other hot policy issues such as housing and mental health. This occurred this year, or that occurred this year, where proposed legislation that was not addressing COVID did not proceed through the legislative process. The budget deliberations may also focus only on targeting resources to addressing COVID-19. And again, when looking at addressing COVID-19, we're looking at health, we're looking at education, and we're looking at other areas such as the economy. So you can proceed with the next slide. This slide shows who the chairs are of the various policy committees and the fiscal committees. Next slide. Next slide. Okay, so there are 6 points in the legislative process where stakeholders and the public can provide their opinion, also known as their positions on proposed legislation. The 6 points are at the policy committees, which for our purposes are the health committees in the Senate and the Assembly, the fiscal committees, which are referred to as the Appropriations Committee in the Senate and in the Assembly, and on the Assembly and on the floors of both houses, both the Senate and the Assembly. And lastly, if a bill, proposed legislation, successfully passes through the legislative process, then the last point where input can be provided is to the governor. With regards to the budget process occurs simultaneously and has different timelines. Opportunities to provide input or testimony regarding a position on a specific budget proposal occurs at the budget subcommittee level first. So for the budget, it would be the health budget subcommittee, then the full budget committee, and then the conference committee. So there are numerous opportunities for the public and stakeholders to provide their input to the budget. Communication with legislative budget staff and the Department of Finance staff is key throughout the budget process in order for your input to be reflected in the analyses and in the input that's provided to the budget and subcommittee members. Okay, next slide. Okay, next slide. Okay, so please keep the following in mind. The leadership of both houses of the legislature develop their priorities on policy, including legislation and state budget. Regarding the state budget, the governor submits proposed state budget to the legislature by January 10th, and the state legislature must submit its budget to the governor by June 15th. With regards to, next slide. Okay, with regards to legislation, the governor has 12 days to act on proposed legislation on his desk during session, and the governor has 30 days to act on legislation after session. Regarding policy development, who are the key players here in California? They include the governor and staff, the California legislature, key committees and key staff. This also includes the legislative caucuses, because the legislative caucus, like the legislative Latino caucus, also develops its priorities. The California Department of Finance, the California Health and Human Services Agency, which includes under its umbrella the California Department of Public Health, the California Department of Healthcare Services, the Office of Statewide Health Planning and Development, CMA, the California Hospital Association, the California Conference of Local Health Officers, and of course, the National Hispanic Medical Association and other statewide health organizations and other statewide health advocacy organizations. Next slide. And the statewide advocacy organizations would include organizations such as the California Primary Care Association. Other health professional organizations or other organizations would include, well, it's not organizations, but other stakeholders would include pharmaceutical firms and insurance companies. Next slide. So what is NHMA and its role with regards to policy development? Well, you should continue to develop your legislative and budget priorities, both at the state level and the federal level. Continue and maintain your policy and advocacy roles, again, federal and state. Maintain existing and establish new relationships with key policymakers and staff. With regards to the legislature, after an election, a general election, new legislators enter into the legislature, which you should introduce yourself and establish a relationship with the new legislators. And also there may be a change in terms of who are chairpersons of the policy and fiscal committees in the legislature and a turnover in staff. So it's important to not only continue your existing relationships with legislators and their staff, but also to develop new relationships with legislators and newly elected legislators and their staff. Again, identify and determine when to testify on health legislation, when to continue your relationship with allies, such as your continued work with other medical associations, also with other health professional organizations such as the National Nurses Association. Also keep in mind the necessity to establish new allies as well. And it may not necessarily always be in the health arena, because just depending on your priorities, you may need support, let's say from allies in the area of mental health or in the policy area of public education. Next slide. I think that's my last slide. So this is very quick. And I think the most important role that NHMA has is to continue to maintain and develop its communication with its members and to identify areas of participation in the legislative process or the budgetary process of its membership. And with this, I will hand it over to Mr. Mahik.
Oh, Dr. Shapiro.
Oh, I'm sorry. I'm sorry, Dr. Shapiro.
I will do a quick break. We have a couple of minutes here. I would really appreciate if you have any questions, please. This is a good moment to actually send it to us. I am checking here the chat. There's a couple of questions here that are very important. One of them is, if I'm a student, how can I actually start getting involved with all the stuff that I'm hearing? I want to be an advocate. How can I do it?
A student in Sacramento?
Actually, it doesn't define here, but
okay.
Probably someone in California.
Let me ask Kimberly, only because you are our guest here from Sacramento and an assemblyman's staff. How do you work with student you have internship opportunities and other things for students? And I know it's COVID-19, but
Yeah.
what do you do in the normal lifetime?
In a normal time, there are ample opportunities for internships, both for high school students, college students, and sometimes even graduate students. Oftentimes, it really is to get your feet wet and get into the office. You're welcoming folks into the office, which actually is a pretty important role. I think folks don't realize you see every single person that comes in, get introduced to every single lobbyist, every legislator that might walk through a particular office. So those are opportunities. For myself, I actually started in the Capitol as a fellow through the Capitol Fellows Program. And so it's a year-long program, and essentially it's an on-the-job training where you work as staff to an elected, either a senator or an assembly member. So if you have really deep interest in that, I really encourage you to check out the Capitol Fellows Program. You do have to be a college four-year undergraduate, so that's one requirement. But other than that, there's a lot of opportunities in terms of internships to get involved.
Thank you for that answer. And sorry, Kimberly, you're on the line on the next question too. I have a question from Dr. Diaz. He's asking that he's very interested on actually working with and collaborating with Dr. Pan. He wants to create like a program regarding Spanish and other languages, Mandarin, Chinese. He puts another a list of other languages. What's the best way to be in contact with our Senate, with Dr. Pan or anybody on Senate?
Yeah, I would encourage you to reach out to our scheduler in Dr. Pan's office. If it's a specific issue regarding language translation, I'm happy to talk to you after the call at some point. Department of Public Health isn't actually the entity that works with that. It's really the way that our laws are structured. It really falls on health plans and health systems to do that. And so you're actually looking more at hospitals and Department of Healthcare Services, or even the Department of Managed Healthcare on some of that stuff. And so, us at the Senate Health Committee or Dr. Pan's staff, we'd be able to kind of talk through that with you of how to navigate some of those things. Yeah.
Thank you very much, Ms. Chen. Right now, this question is for Dr. Carrasco. I have been hearing a lot, and part of the things that we have in front of us is the ability to make changes to our heart and our heart health. We know right now that COVID is just showing us the acute part of it, but we're not seeing the chronic aspect of the disease. What are your thoughts or feelings on the current evidence? I know that it's kind of a open-ended question, but with the current evidence, what do you think that at least we know right now about the chronic effects of COVID in patients?
Wow, that is a very loaded question, and what loaded only because what I have heard is that for some patients, there are sequelas that are going to last for a very long time. One of them that we've been hearing is patients that leave the hospital end up feeling very fatigued and even having shortness of breath for quite the weeks after they leave, depending on the pneumonia that they developed and what have you. So there is that concern, and more research is being done to understand what are the permanent or the sequela and how long they're going to last for some patients. And all we could do right now is the emphasis is in being a very compassionate doctor when you see these patients. If they're saying, doctor, I just don't feel well, don't just say, oh, you're going to do better. No, do not do that. You have to be compassionate and empathetic and say a lot is still being learned about this disease and in the aftermath. And we need to be patient. And I, let's see what we can do. You have to be considerate of that, because there is so much that I've heard from patients that have gone through the illness. And I currently have a 54-year-old who's still on oxygen, and his only comorbidity was obesity. And luckily he did not end up being intubated, but he still needs the oxygen and getting around. And he is 3 weeks out from the hospital now. And so it's very real. So there is going to be mainly it's the fatigue is going to probably longer time last. And then the oxygen problem with the breathing is going to be a problem. And for the young people, you're going to hear it more. For the elderly, remember, the elderly don't move around as much, so their complaints are not going to be as extensive. They'll still be present, but the young people, this is really holding them back. It's majorly an issue with them.
Thank you so much. Thank you,
Elon?
Yes.
Dr. Shapiro, I don't know if you finished your question. Did you finish your questions?
We're good.
Okay. I want to thank everybody on the panel, but I wanted to say especially thank you to the next panel who will start right now. I have to leave. I actually have some family here from California. I wanted to say a special thanks to Kimberly from Senator Pan's office and Assemblyman Joaquin Arambula. I just want to say that we've just been discussing the importance of policies for next year in California around COVID, especially remembering that the most serious patients are our heart disease patients and of course, diabetic and obesity. But we can't do any of this without having more Latino doctors and Latino nurses and health professionals. And so I know that Margarita is very involved, and Ilan Shapiro very involved in our Southern California chapter. And Jessica Nunez is our leader of our Northern California chapter. And we want to be more present in this next legislative session with all of you to help with policies and supporting your efforts. Even with limited budgets, we need to step up and do more for our communities in California.
Thank you so much, Dr.
Thank you,
Rios.
everybody.
Right now, we will be switching gears because I know that we have a couple of panelists that from the next round that they have a tight schedule. Then thank you so much, Dr. Chen, Ms. Zaragoza, and of course, Dr. Carrasco. A pleasure always to hear from you. And this is an open conversation, and we will probably hear from us when we have the vaccine and other interesting stuff next year. Happy everything.
Hi, everyone. Margarita Loaiza, I'm a family medicine doctor at Venice Family Clinic. And we're going to have our second panel will start now. And it's California healthcare workforce development in the post-COVID-19 era. And we have our first speaker. Do we have the first speaker slides ready? So on our panel today will be Dr. Arambula, who is an emergency medicine doctor and represents the 31st district in Central Valley and the first Latino physician to be an assembly member. And we have Marco, I hope I don't say your name wrong, Marco Mijovic. Am I saying it right? I'm saying it wrong. Deputy Secretary for Program and Fiscal Affairs of California Health and Human Services. And of course we have Jeff Oxidine, MBA and PH. He's the health executive, educator, author, and consultant for over 30 years. And he's California leader and consultant in healthcare workforce and diversity. So Dr. Arambula is our first speaker.
Buenas tardes y gracias por la oportunidad para hablar con ustedes este día. Vanna empezó en español para dar un poco de respeto a mis abuelos. Mis abuelos que entraron de este país sin papeles y sin miedo para trabajar todos los días en los campos como trabajadores o campesinos. Y ellos no iban algún día de escuela, pero dice a los niños y los nietos que son importantes que ir a la escuela. Esta es una raza que yo trabajo duro y ser un doctor para regresar a nuestra comunidad para apoyar a los campesinos y trabajadores. Y para 10 años trabaja como un doctor en una sala de emergencia en Selma, el capital del PASA en el mundo. Y trabaja duro y mira bastante de pacientes, 50,000 personas. Y durante mi tiempo en la sala de emergencia, sabe que yo no puedo ver a mi gente solo y que son importantes para cambiar a cómo van a tener las oportunidades de los mismos latinos en el futuro. Esta es una raza que ahorita yo soy un asambleísta que trabajo en el capital del estado y me gusto para ayudar y apoyar a nuestra comunidad porque mis abuelos están en mi corazón y ellos son la raza que yo ayuda a ellos también. Now I'm quite pleased to be with you here today, and if it's okay, I am a little more comfortable in English, but I always like to start by giving some respect to my grandparents who came here without papers and worked their entire life in the fields. Now, it's difficult when you're here in the Central Valley if you're not sure where I'm from. I was born in Delano in the middle of the farm workers movement. I can remember the organizing of Cesar Chavez and Dolores Huerta, who I was with just earlier this week, and know the importance that it has for us to be able to own our identity. Being able to own my identity was a core and central piece to me being able to connect with my patients, to be able to establish the trust, to be able to communicate in a native tongue. It allowed us to break down barriers and really allowed our patients to feel comfortable to discuss some things that aren't always easy for our community to talk about. But I knew after spending 10 years in the emergency department that I was not going to be able to see my people alone. And I had to learn how to ask for help. I had to actually start by asking my wife if I could run for office, and lucky enough, she agreed. And we did run for the assembly where I've served since 2016. And while in the assembly, I've made access to healthcare and improving workforce and diversifying our workforce a priority. This past legislative cycle, I introduced AB4 because I believe that healthcare is a human right. And because of that, I think all income eligible adults should have the opportunity to be on Medi-Cal regardless of immigration status. That's how I worked when I was in the emergency department. I took care of the next person who needed my help. I wasn't asking for what was in your passport or where you came from. And I think that we need to realize, especially during this pandemic, that the health of each of us is dependent on the health of all of us. So I enjoy being able to work on policies, to come up with some of the solutions for the issues that are fighting us right now. And I would be remiss not to speak about COVID-19, which, as I like to say, is the pandemic of the century. And just to make sure we recognize that the health disparities are happening in real time to our Latino communities and need our advocacy and effort. Now, I'm a pretty forceful advocate in my community for raising my voice for the Latino, the farm working community. You may have heard that in August, we were a hotspot in the nation for how we were dealing with COVID, and I will share now in October that we are seeing significant improvements by listening to our scientists and by working with our public health experts and by helping to educate all of our community. But I want to talk about some specific programs that I believe need to be highlighted as they may be helpful for those of you across the United States. As we have Jeff later on coming on this panel, I would want to make sure to highlight first and foremost HCOP. HCOP is a Health Career Opportunities Program that has a federal program right now. State of California has had an HCOP program for a number of years, and these are programs that are pathway programs that allow students to figure out how they can get into a health career field. Too often, our Latino kids who are in school struggle to be able to get into health career pathways because they've never had anyone in their family who's either gone to college or experienced a health career. I spent a lot of my time while practicing medicine, working with the Doctors Academy, helping to give those experiences, and believe that HCOP is a wonderful way for us to work with many of our four-year institutions and potentially our community colleges to make sure that we're providing those pathways. For anyone who wants to become a physician's assistant, RN, an LVN, a CNA, a respiratory tech, an occupational therapist, anything within a healthcare field, helping to provide those skills, helping us to diversify our workforce is a strength that we appreciate here in California and one that we should lean into. It's how we will ultimately get better outcomes. And it's one of the ways I think we can start to affect the disparities that we're seeing in COVID is by starting to realize we have to make a difference within our healthcare workforce. Now, I'm troubled when we look at California after the last 30 years, and we have not seen a significant increase in our percentage of Latino medical doctors across our state. I read recently that we have the worst doctor to patient ratio for Latino medical doctors in the entire country. And I believe we must do much more in a state as diverse as ours to be intentional to make sure we are coming up with solutions that help us to fix that. One of those solutions is a program that we authored, a bill that, a pilot program that we codified, dealing with international medical graduates, doctors who have skills, both cultural and linguistic skills, who are able to come here, show that they have proficiencies, who then will go to rural and often underserved areas to help to give back to our community, is another great way for us to help to continue to diversify our workforce. But I will make sure I leave enough time for us to have questions. I've actually not always used to speaking. As a doctor, I was used to asking questions and waiting for the responses. And so I would look forward to the chance to be able to answer your questions. But since we are on a national call, I would be remiss not to talk about what I believe should be a priority for all of us in the first 100 days of this next presidency. And that's to advocate on our patients' behalf for the need for comprehensive immigration reform. We have 11 million people who are in the shadows, who are struggling to be able to make ends meet, to be able to pay for the prescriptions that I and you write for them. And one of the easiest ways for us to deal with that is to treat them like the human beings that they are. And so I oftentimes think as a doctor, we are our patients' educators as well as our patients' advocates. And so I would ask this group to help to join us in advocating to our federal partners to try to pass comprehensive immigration reform. Now, I'm quite pleased on all the work that we are doing in the state of California. I enjoy working with Marco and Jeff, who will be speaking after me. And I'm so glad that you invited me here today. Thanks for allowing me to participate.
Thank you, Dr. Arambula. We'll leave some time at the end for questions. Jeff, did you want to go next? I know you had to leave at 5.
I'm okay. It's up to, yeah, I'm happy with Marco going next, or I'm happy to go next. It's fine if I'm up. So I guess it's appropriate to follow Assembly Member Arambula, and appreciate the emphasis on the importance of increasing workforce diversity and on programs like HCOP in addition to immigration reform. I'm just gonna, my presentation today is gonna comment on the work of the California Future Health Workforce Commission, which I had the privilege of being the co-director of, and which produced its report in February of 2019. And since that time, many of us, including Member Arambula and Marco, have been working to help implement the recommendations. Briefly, I'm going to talk first about the challenges and then the recommendations and how they apply in this post-COVID era to helping get the diversity of the health workforce that we need going forward. So just a quick review of the some of the challenges in California around health workforce, as has been indicated by the Assembly Member and by Dr. Rios, that we have a huge challenge in terms of the diversity of the workforce compared to the Latino population, as well as African American and Native American. But we also have big challenges related to shortages of providers, particularly around primary care and behavioral health and home care. And we have a maldistribution in different regions, the Central Valley, the Imperial Valley, the Inland Empire, and many other areas. South LA have severe shortages of providers relative to their population. And then now with COVID, the health organizations that need to hire folks are struggling with stability and financial challenges. We don't have the cultural linguistic competence that we need, and everybody is trying to deal with COVID in an effective way now and to start building a recovery. So many challenges. Next slide, please. We've already talked about the disparity here. Just to refresh everybody, 7% of the physicians are Latino compared to 38% of our population. The next slide. We have a huge issue with not enough Spanish-speaking doctors or clinical providers relative to our needs in the state. And we know that this disproportionate impact that COVID-19 has had and the economic crisis and systemic racism has had on our communities of color and our low-income communities in the state. And we've got an opportunity now, as challenging as it is, to advance the recovery and build our future health workforce by making the right kind of investments. And we'll talk a little bit about that. Next slide, please. The Future Health Workforce Commission was chaired by Janet Napolitano, then the president of the UC system, and Lloyd Dean, the president of the Dignity Health. And we had 22 leaders from throughout the state who were part of it. Came up with 3 areas of priority focus: primary care and prevention, which includes public health, behavioral health, which includes mental health and substance use, and healthy aging and caring for older adults as the 3 consensus areas where we need more future workforce. We also need a more diverse health workforce and more equitable pathways into the health workforce. And the goal is to have the right people in the right places with the right competencies to advance health and prevent future health and injuries. Next slide, please. So we came up with 3 strategies, and I'm going to talk now about the recommendations under each strategy. Next slide. The first strategy is increasing opportunity for people in California to become health professionals. As Dr. Arambula mentioned, we have plenty of people that, we have the large Latino population. Many of them are in colleges. They're interested in health careers. We've got to give them opportunity to be able to get in a pathway and to get into health profession schools and come back and serve their community. The second is we've got to make sure we have the educational capacity and that we're preparing people with the skills to put people in the right places with the right skills. Then lastly, we've got to utilize the workforce that we have. We're not going to be able to have enough people in the time that we have, nor could we afford to do that. So we've got to have the people that we have more capacity and more effective. So those were our 3 strategies. I'm now going to highlight the recommendations under each one and give you a little bit of a status update. The good news is we're making great progress, but we've got a ways to go. Next slide. So in under strategy 1, increasing more opportunity for people from California to become the next generation of diverse health leaders and professionals. This is the area where we have not made as much progress. Fortunately, Assemblymember Rambula has stepped up as well as others to try to help advance these recommendations. Understanding, I think there's a large understanding that we need to invest in the pipeline. The economic challenges with COVID have made that more difficult, but I would submit to you that it's an imperative now, given that the communities that have had the largest adverse impact from COVID, we've got to invest in people from those communities now as part of the recovery, as well as have them be future leaders in their communities, and to really have that diversity of the workforce we need to address health disparities. So these are expanding programs that work. I'm going to share a couple of those in a minute. We have a lot of the best pipeline programs in the country in California. Dr. Arambula worked with the Doctors Academy, led by Catherine Flores. There's many others. And so we have great programs out there that are working. They're just not scaled. They're not sustainable. And we need to really lift them up and expand them. The second was the HCOP program that Dr. Arambula mentioned. And I'll go into more detail in a minute about what that involves. It's really about providing college students who've already gotten into the pipeline. They're already in college. They're ready, they're poised, they're focused, they want to go into healthcare, helping give them the opportunity they need to get there. Finally, we need more scholarship support. I know Dr. Rios mentioned that NHMA has scholarships, and I was excited to hear they have public health, they have PA and medicine and pharmacy. We need that, but one of the biggest barriers, when I talk to Latino students and other students, and I've been working with college students to pursue health careers for over 30 years, one of the biggest barriers for them is thinking, how am I going to pay for health profession school? And that's affecting not only their choices of profession, but their choices of where they would practice afterwards, and their ability to really serve in the way that they want to serve. So we have great loan repayment, which is really necessary, but it's not sufficient because a lot of people are not pursuing it because of the front end costs. So coming up with this was creating a scholarship program that would provide incentives for students from California, from under-resourced communities, if they choose priority professions that are needed, then to be able to provide them with a scholarship in return for a commitment to service in underserved. The next slide. So this is an example. These are some of the Doctors Academy students. It's as I mentioned, it's more urgent and important than ever that we invest in the pipeline, even though we've got urgent COVID. Next slide. So I mentioned scaling proven programs, and somebody asked in the previous panel, how can students get involved in pursuing these health issues? And these are proven programs that are in our state, like Health Career Connection, the nonprofit that I run that's been around for 30 years, statewide program. And these are programs that when we look to scale up, that this recommendation to invest in and scale proven programs, these are just some examples. We did a study that there are over 380 pipeline programs in our state. So investing in these programs would pay huge dividend. Next slide, please. We also, next slide. There also are statewide and regional programs that we need to invest in. We're a very large and complex, diverse state. So we need to do work, have pathways in all of the regions that are most critical to prepare people at the local level to get into these health professions and to connect them to employers and local educational institutions, and then to connect them to statewide entities able to help. So the good news that once again is we have a lot of programs that are in place already. And you can see some of the regional programs are in the areas where we have the greatest need. The Inland Empire, the Coachella Valley, Salinas, and the South LA. So these are programs that we can invest in now and expand and connect the dots amongst them in order to have greater impact. Next slide, please. So bottom line is students, in order to be successful, if we're going to build that future diverse workforce, we need to enhance their exposure, their experience, their mentorship. We've got to provide better advising, better academic support. We've got to engage the parents too. And then we've got to give them psychosocial support for what they're dealing with right now. And then we've got to help them get jobs. You know, the bottom line is people need economic opportunity, and then we have to prepare them for health profession schools. Next slide, please. So that's what the HCOP programs that Dr. Arambula mentioned and is supporting would do. We would take 20, first of all, we established a statewide HCOP program, and that program would pull together programs, 20 to start with, HCOPs on different campuses. We're envisioning 5 in the CSU, 5 in the UC, 5 in the community college, and 5 in private colleges. And they would provide those set of services that I just mentioned that students need. And many of these programs they've already done this. They just don't have the funding and the scale to do that. They would target undergraduate students and students from disadvantaged backgrounds. And there's a proven track record of these programs. They've been around since the 70s. We just haven't invested in them in California on a large scale. And the outcome of this recommendation would be 25,000 new underrepresented health professionals. Next slide, please. Other priority recommendations. So those were the ones about providing opportunity. These are those opportunities to build the educational pipeline. The good news here is we have done a great job in our state of expanding the number of primary care physician and psychiatric residencies. And there are good proposals underway to support the PRIME program expansion and recruiting students from under-resourced and rural communities to practice in community health centers in their region. Those are ones that are going forward but not really acted on yet. The next slide, please. These are recommendations related to enhancing the effectiveness of our current workforce. And Member Wood championed AB 890, which was signed by the governor to put in place the maximizing the roles of nurse practitioners to help fill the gaps. And there's also investments in increasing the capacity to produce more nurse practitioners. They've demonstrated their ability to serve people on Medi-Cal, to serve people in under-resourced communities, and to be effective providers. We also are scaling a psych nurse practitioner program. The foundations are investing in this with UC. And then we're really working on building up community health workers. And the governor signed a bill on peer support providers as well. So there's a lot that we recommended that's in motion that will bear fruit. But there's more work to go. Next slide. So some additional recommendations. There's been great investment in loan repayment programs on behalf by the governor and by our state. We are investing also in expanding medical schools, particularly in the Central Valley, the Inland Empire, and in South LA where we really need them. And there's the California Health Corps that was formed and is actively working on the COVID-19 mitigation. And the one thing that hasn't happened is the post-bac program, which is a very low cost investment. But these are students who've made it to, they want to become physicians or pharmacists or nurses. They've made it to that point, and they just need some support in order to get over the final hump to be able to get into medical school. We have great post-bac programs that have done a wonderful job. So these are additional recommendations of the commission that are underway and that we could support. Next slide, please. So we also have to invest, COVID-19, it shows we have to invest in the public health workforce in a way that we haven't before. And we're paying the price now for not investing in the public health workforce and the public health infrastructure. Some of the commission recommendations were around building academic health, public health departments, partnerships between schools of public health and large health departments to make sure students get exposed to governmental public health, get their foot in the door, and get jobs in governmental public health. There's also work at the regional level that we're proposing around building the capacity to work on social determinants of health between health systems and between public health departments. There's been significant investment. Kaiser Permanente, many of the foundations have invested in contact tracers and case investigators through Public Health Institute, with a focus on also preparing them to be able to go into the public health workforce and stay in that pipeline when they're done. And we need a lot of other things to enhance the public health workforce. Next slide, please. So there's a big opportunity need, and we need a statewide infrastructure to do this work. Right now, a lot of people are collaborating to do the work together, but the bottom line is we need a central statewide entity to help implement this work, to help report on it, ensure there's accountability, and we need to connect that to regional entities that are doing the work in their areas, and then are also making sure that we're coordinating between employers, education, and the students to get what they really need. Next slide, please. And then finally, what's the return on investment? You know, this is from the top 10 recommendations. You can see the level of impact that we can have by investing in Californians and building the pipelines from these recommendations that we already have in place and that are already moving forward. So hopefully this is something we can all work together to move forward next year. Next slide. And the results are that this is what we want to have more of. This is Dr. Evita Limon Roca. She's one of my former students through Health Career Connection. She is from the Inland Empire. She did an internship when she was an undergraduate student, which really inspired her to become a physician who was also a public health leader and an advocate, a policy advocate, a champion. And so you can see where she went to medical school, and she last year was the National Hispanic Medical Association Resident of the Year. And she has now returned, and she is serving in the Inland Empire, her home. She met her commitment to come home, and she is a child and adolescent psychiatrist, which is one of the hardest to fill roles, particularly a bilingual one that we have in the state. So she's the product of these kind of pipeline programs that we're talking about. So by investing and scaling those, we will have many more of her that will have a huge impact on the community. So I encourage us to work together to make these things happen next year and going forward. Thank you.
Thank you, Jeff. I'm also a product of Pipeline Program, so really excited to see your work. If we could have Marco next, and then we'll save questions till the end.
Great. Hi, everybody. I hope everyone is doing well, and it is just such a pleasure to be joined by Dr. Arambula and Jeff. You know, it is a great pleasure with Dr. Arambula in particular, as he chairs the subcommittee #1 on health and human services on the budget side, and our continued partnership as co-equal branches of government on a lot of different fronts. So I am uber grateful for his leadership on the health and human services side. And obviously Jeff and all of his work, not only with the commission, but more broadly. My name is Marco Meach. I'm the Deputy Secretary for Program and Fiscal Affairs at the California Health and Human Services Agency. I also serve right now as the Acting Director of the Office of Statewide Health Planning and Development. It's also known as OSHPED, for those of you who don't know California lingo. And I'm just really honored and proud to be with you all today. I want to start really by just kind of acknowledging a number of facts that I think COVID-19 and this pandemic highlighted for us. And first and foremost, the disproportionate impact of COVID-19 on our Latino brothers and sisters and friends and neighbors. And if you look at the data in California alone, you know, roughly 39% of the population is Latino. When you look at the cases, 61% roughly are really focused on our Latino. And then when you look at deaths in particular, roughly 49% of deaths are amongst our Latino friends and neighbors. And so I think that this just amplifies the disparities and health inequities that we have seen for a long time. But I think that this pandemic illuminates it in ways that I think we haven't seen before. And I think it calls on all of us to kind of recommit our work around how we look at ways in which we can eliminate some of those inequities, health disparities. And I'm really proud of California and the work that we've done, but I think we have so much more work ahead of us. And one of those ways in which we can disrupt some of those disparities is by putting healthcare providers into the community who look and speak the same way as their patients. And I think fundamentally that ultimately changes how we engage, how individuals engage with their community. I think in California in particular, we've made progress, but I think we've got lots more progress to make. The organization that I have an honor and a privilege to being part of, OSHPD, does a lot of work around looking at healthcare workforce. I think that Jeff's report with the Workforce Commission gives us even more work to digest and think about how do we really look at ways in which we can beef up that pipeline? How can we bring more Latinos into the healthcare workforce profession? It also enables us to think more holistically about the programs we have, whether it's a loan repayment program, a scholarship program, or a grant program. How do we ensure that we're partnering with the appropriate organizations at the local level so that folks know what resources are available to them? Most people don't know what OSHPD is, and I don't expect them to know. And, you know, I am a refugee who came to this country, whose parents didn't speak English, who didn't speak English. My parents didn't have a chance to help me through the process of college and scholarships and loan repayment and all those things. And so I think it's upon all of us to think about even some of the minutia in terms of thinking about scholarships that might be available and connecting folks to the resources. There's ample resources available out there. I think it's trying to figure out who are the trusted messengers in the community and how do we really lift them up to enable the younger folks to really take advantage of some of those. And so I think part of our work here at the Health and Human Services Agency and certainly at OSHPD is to think about how do we get deeper and wider into the community? How do we get closer to the people? How do we make sure that we're delivering programs and services that are person-centered? Person-centered notion is a healthcare term, really the idea that you're providing holistic care, but that's true for government services. We certainly don't want to be providing services to individuals where, you know, in my agency alone, you might be entering 5 different programs through 5 different doors, providing the same set of information 5 different times. We really should be thinking about more holistically, how can we be wrapping ourselves around the individual to ensure that they have adequate healthcare and social services. And that leads me to kind of my last point, which really is around how do we connect the concepts of both social service, the social services model and the health model. I think for many, many years, these two things were separate, right? And I think that more and more, and I think post the Affordable Care Act, as we changed not only coverage, when we did coverage expansion, but then when we also looked at payment reforms and delivery system reforms, we began to realize kind of the notion of social determinants of health, the things that really impact one's health. And I think too often people say that one zip code is more determinative than someone's genetic code, and that certainly is true. But I think part of that is you can give someone access to coverage. We're lucky in California to have expanded both our Medicaid program as well as created our own exchange with Covered California. But you can give someone access to healthcare, or you can give them access to coverage. But if they don't have food on the table, and this is where WIC and our CalFresh program are critically important pieces, or even our CalWorks program and the home visiting work that Dr. Rambula and others did with us in terms of expanding and building that program, those are all pieces of what we call these social determinants. So when you do send that kid to a doctor and they get an antibiotic and that kid has some food and a roof over their head, that whole delivery system works in a more holistic way to create the appropriate health outcomes that we really want. And so for me, I think it's such an honor and a privilege to be part of this panel, but more importantly, to be in a state where we're doing so much great work with our legislative colleagues and colleagues in the community like Jeff and his team around ways in which we can lift up and ensure that not only our healthcare workforce is representative of the people that it serves, but that we're really true to ourselves in terms of trying to deliver programs and services to meet people where they are and they ultimately meet their needs. So I'm really humbled to be with you. And I just encourage, I'll take one moment. I couldn't do this. My boss, Dr. Galley, would be quite upset with me if I didn't. You know, this is a really big opportunity for us collectively to make an impact in this pandemic. And I think Dr. Arambula would agree with me as a physician in the ER. There's no greater thing that you can do right now than making sure that you're protecting yourself and your loved ones by physically distancing, wearing masks, and doing those things that make sure that we don't spread the virus. We know it's hard. The mental health burden on many of us, the anxiety, the depression as a result of not being able to be around loved ones and family members is hard. But I think we have to do it in order for us to ensure that we can get our kids back to school, that we can open up our economy in a profound way. So I would encourage each of you, whether you're in California or somewhere else in this country, that you really kind of take your personal onus around making sure that you're taking those steps to not only protect yourself, but to protect those around you. So I'll pause there, and I look forward to participating in questions and answers.
Thank you so much. So I'll take the opportunity now. I'm looking in the chat to see if we have any questions. I did see someone's comment where they mentioned, what about free medical school? And if someone could start there. I don't know why I'm laughing, probably because I paid so much for it.
Well, I think it's great to have, the Kaiser Permanente and others are stepping up and making medical school free. And also at the same time, I think they're looking holistically at who they're selecting for their schools, and they're prioritizing diversity and people who want to address health inequities and transform communities. So I think it's a real positive thing, but I think it's not going to cover enough to make all of the changes that we need to make. So I think, and get all of the people into the field. So I'm hopeful that some of the other things that we talked about would also be possible. And we have to increase our medical school capacity as well, which we're doing in order to produce enough people.
And I would just highlight, if I could, the program that Marco spoke about, the loan repayment program. If you are not familiar with this, it is significant and will help you to pay back many of those medical school loans that you incur. I believe it's $300,000 for 5 years, $60,000 at the end of each year, if you're willing to go to an underserved area and see a high percentage of Medi-Cal patients. And so I would love to encourage you to take a look at that program. One of the reasons we designed it the way we did was because debt load influences the decisions you make regarding residency. And so if we could help to affect those medical loans, we could help people to choose primary care, which allowed them to stay more likely within their communities as well.
Yeah, the loan repayment program at Venice Family Clinic, a lot of the physicians that work there have gone through it, and it has really helped us retain doctors and attract doctors that right out of residency. We have a question in the chat about when will we see UC Merced Medical School?
Well, that's in my wheelhouse. And you know, I will say I'm quite proud we were able to secure $15 million ongoing this year for a medical school in the Valley, and that is a start. If you're not familiar, I'm tracking it pretty closely. We had a cohort start last year, so we had 6 students from UCSF who have already started going through. We accepted another cohort this year. The plan is for us to transition, is to increase that cohort size through the ongoing money we have. We need some brick and mortar. We need to create some space for those students to be able to be taught while they're in Fresno, with the goal eventually of transferring to UC Merced. But this is a spectrum, and it's going to take us a while. And so oftentimes it's one step in front of the other, and really trying to increase that cohort size. And I will just add, while I focus mostly on the public side, there is private interest in stepping into this space as well. And so I think we're going to need an all of the above solution to help us to meet the need.
I don't see any other questions in the chat, but I wanted to see if, oh wait, here's one. So how can NHMA assist the Health and Human Services Agency, California, DPH, in addressing the issue of vaccines specific to COVID-19? Is there planning right now regarding distribution and cost of vaccines? It's a little different from our topic, but.
Yeah, no, this is Marco, and I'm certainly happy to answer that question. We're doing a few things. So we just recently submitted a very comprehensive plan to our federal partners around kind of how we look to roll out the availability of the vaccine in California. I would say, I think a few things from a clinical perspective, certainly the providers who are on the Zoom, it's just making sure that people have the facts around the efficacy of a vaccine. I think too often things can certainly get politicized, and I think it's really important that we are educating folks. And my particular worry is making sure that people who are disproportionately impacted, and the facts that I alluded to, or the data that I alluded to earlier on, around making sure that Latinos know that that they are part of this, and that this also has a benefit them. But it's equally important for us to make sure, and that we're advocating that they are part of these clinical trials, so that we know the impacts that this might have on them as well. So for me, I think what we're trying to do is really think about how do we ensure that we do mass vaccination across the state? What are the community organizations that we can work with in order for us to be able to make sure we distribute that? And as the governor alluded to, and Secretary Gali alluded to a few days ago, around just creating our own review process here that validates the vaccines approval process, so that that we have the ability to say that this really meets the scientific standards. And we're so grateful to our West Coast partners, because there's a number of other states that have joined our pack and are really looking to work with us on that. I think from a clinical perspective and an NHMA's perspective, it's not only important to educate your patients in your clinics or in your different settings, but it's equally important to make sure that you're an advocate outside, and that you're educating folks in the community around the importance of vaccination. I will just say, in terms of the COVID vaccine, it might not be available now, but the single best thing people can do is get the flu shot. And I think that this is yet another opportunity for us to all, as a part of a healthcare community, to make sure that people are aware of the impacts of that and what they can do to protect themselves there. But I think more to come. Visit our website at covid19.ca.gov for more information around how you can engage and what our plans are with regards to vaccines more broadly.
I'd just like to emphasize a comment that I didn't go into detail enough on. I think that the distribution of vaccines, and what Marco was talking about, educating our diverse populations about vaccines and about getting them distributed, along with contact tracing, case investigation, connecting people to social needs, economic development. These are all opportunities to get people from the communities that have been most disproportionately impacted to play a role in the recovery, in the mitigation and the recovery, and then to get into the pipeline to become health professionals. So these, I know we have the Health Corps, which is really exciting at the state level, and we perhaps could have a community health corps version of that, where we're intentionally getting more people from the community. And I know Public Health Institute is doing this with contact tracing already, but having more people involved in the solution now, getting them income, which they really need, giving them hope and opportunity, which they really need, and that their families need at this point in time, and then having them be on a trajectory, getting supported through HCOP and the other kind of programs we talked about, to become health professionals going forward. So it'd be great. I know we're looking to make the case to invest in things in the pipeline, perhaps tying it more to the COVID-19 solution would be a way to help do that going forward.
Thank you for your comment. We have another question that says, does NHMA have representation on the California COVID-19 Scientific Safety Review Work Group? I don't know if anyone can answer that one.
I'm not sure that there's a particular NHMA representative. The list of physicians or clinical experts, scientific experts that we are pulling from across the state is available on our website. I am not 100% certain whether any of them are NHMA physicians.
Okay, thank you. Dr. Flores has a question. What can NHMA do to assure that Workforce Commission recommendations are moved forward, particularly for HCOP and the post-bac?
So, Dr. Flores and Jeff, I should just tell you now, I'm planning on reintroducing the bill that we introduced last bill, and so would love if NHMA is able to help support us and tell the story for its need. And so I think that's a good way for us to start. I do think we will need to get into a conversation regarding budget, as it's always about how we help to pay for these things. And, you know, from my side, I always like to look towards some of the sin taxes, some of the programs that are disproportionately affecting our Latino and Black communities, like vaping, like cigarettes, and think if there are opportunities that we can turn that around and help us to diversify our workforce seem like a win-win situation. So would love to be able to partner with NHMA next year on working on that. But before I forget, I heard Marco speak, and I had a moral obligation to stand up over the summer to speak out when I felt that my community was in trouble. But I also feel an obligation to stand up and acknowledge the governor spending and looking into our area. If it were not for his strike teams, the outcomes for our Latino communities would be worse. And I just really appreciate him taking the time and effort to really look at the Central Valley, as I think it made a huge difference and helped us to save lives.
So we have about 10 minutes left. So I want to know if our speakers had any final words or comments that they wanted to give the audience.
You know, the only thing I'm quite proud of where I come from and really believe it's important. So, you know, I thought Marco talked earlier on social determinants of health. And oftentimes it is the struggle that we go through that makes us who we are, and it makes us better because of it. I also think it's important for us to go back to our roots to help to take care of others in our community who are also struggling. I have the privilege of still living in the same zip code that I grew up in, and it's one of the most environmentally and economically challenged zip codes in our state. But it constantly reminds me of the struggle of so many of my patients that they've gone through and the need that they have for advocacy in our state capital. I said it earlier, but I really believe it's our responsibility as physicians. We are looked to as subject matter experts, and those in government need our opinions. They need us to be able to advocate on our patients' behalf, and just want to make sure to encourage you that your voice is important and it's needed and it's appreciated by those of us in civil service.
Thank you. That's an important message, especially for maybe pre-medical students watching or people that hope to be physicians. So I think the screen changed. Sorry, that alarmed me a little bit. Jeff or Marco, do you have any final comments?
Go ahead, Marco. I'll follow you.
Yeah, I just certainly want to express my thanks to the NHMA for inviting us to participate. We talked a lot here about kind of ways in which we can further diversify our workforce, but I think what's really important is for folks to remember those high school students or those college students, and you know, serving as mentors. I know from personal experience, I would not be where I am today if it wasn't for people who really helped me along the way. And so I think it makes a profound difference. And so, you know, what I would encourage folks to do is really try to support particularly younger folks who have a zest and an appetite for getting into the healthcare field. I think that this is only going to get more difficult in the years and to come. The pandemic just has highlighted the inequities and disparities. And I think that we need to figure out ways in which we can support particularly first generation students. It's a daunting process of applying for college or navigating all of the different pieces. And so to the extent that those of us who've gone through it as first generation college students can support those that are going through it to lift them up, we're going to do a huge service to not only the state, but this nation. And so I would just encourage everyone to spend a little bit of time thinking about who are those students who might be first generation Latino high school students or college students who might be afraid of the daunting idea of applying to medical school and not know all of the nuances that it goes into doing it, to maybe help them and think about how to help them. Because I think there's a lot of folks that do it. We just need to give them the opportunity. And I think too often we haven't given enough people the opportunity. And I'm really proud to be part of a state where I think together we certainly do that. So I just would encourage us to really think about how we do that for the younger generation.
Thank you so much. I totally agree with you. Mentorship is so important, and NHMA is working on that. And it's really important for our first generation students to have a mentor, because sometimes they can't, as you alluded earlier, go to their parents for help.
So I would agree with both of you, and I would just say that it's important to work at the individual student level, and at the same time, we also need to work at the programmatic level and at the policy level. And we have to coordinate them all so that we are, the people, they are out there. We have students, we have Latino students, other students who are from the communities that are most underserved, who want to become health professionals. And so if we can work at that individual program policy level on a large scale, and we can make the necessary investments starting now, even given the circumstances, I'm confident. It's going to take a long time, as Assemblymember Ambula said, but we need to start now in order to be able to make that happen. And it has to be at the high school level, but it also has to be at the college and the post-bac and the medical school level. And as you said, getting people loan repayment to work in underserved communities and then retaining them in those communities. We have to have a systematic approach. And I think our commission recommendations lay out a good roadmap for that. And hopefully with a shared ownership approach with the government, with the legislature, with private sector, and with education, we can all, and with advocates like NHMA and others on the call here, we can all pull together to make this happen. So look forward to doing that with everyone.
That's great. Thank you so much. Thank you everyone for joining us today. Thank you, Dr. Arambula and Marco and Jeffrey. It has been really a pleasure to hear you and listen to your work. It's very inspiring. Much needed during this time. I know that strengthening the pipeline and all the programs that and policy will really help the future. I know that a lot of Latino pre-meds that get discouraged along the way, but I think that if we build a strong pipeline, we can, we'll see the benefits many years from now. Thank you so much for joining us today. It's much appreciated.
Thank you.
Thank you all.
Thank you.
Thank you, everyone.
Thank you. Goodbye.